Okay, sorry about that again. So I would like to, first of all, one, being a general GP working in a clinic is quite challenging. When I was a medical officer, I used to join a lot of locums in clinics, and I've seen the cases, normally they come from a young age to elderly patients, and they come with all kind of symptoms. It can range from a mild cough to a severe condition. So it's not easy to be a GP, being a frontliner. I know that when I was doing locum, most of the time you see straightforward cases, but sometimes you encounter serious conditions, especially if it's cardiac-related conditions. So if patient comes with symptoms, how do you identify whether this is a cardiac-related conditions? And if it's cardiac-related conditions, what do you do next? How do you manage this patient? And most importantly, when do you refer to a cardiologist? Okay. So during this presentation, I'll be sharing few examples of cases of my patients. So when do you refer to a cardiologist? If a patient comes with chest pain, breathlessness, reduced effort tolerance, palpitation, heart failure, syncopal, cardiologist, and I'll explain to you this in a while. Okay. So if a patient comes with chest pain, all patients, they don't come with a similar type of pain. It varies from each individual. You have typical or atypical chest pain. Okay, the typical normally they present with a central or left-sided chest pain, often described as heaviness or pressing in nature. May be associated with radiating pain. It can radiate to over the arm or jaw. Associated with may have sweating, breathlessness, reduced effort tolerance, rest, or exertion. Whereas the atypical pain, they normally describe as pricking type, sharp, gripping type of pain. And normally the area the pain is at the lower chest, epigastric region, or even the right chest, and may be aggravated with deep inspiration or related to food or movement of body. So if they come to you with chest discomfort, first thing you need to think of coronary artery disease. Okay, if it's not coronary artery disease, other differential will be costochondritis, GI symptoms, GI pathologies, acute cholelithiasis, gallstone bladder, hepatitis, IV dissection, and etc. If the symptoms are vague, or you're not sure what you're dealing with, patient comes with chest discomfort, just treat as CCS until proven otherwise. Okay. So when they come with chest pain, most important, the first thing you do is, whether it's atypical or typical, you should do an ECG. Make sure that this patient has not in acute coronary syndrome. Okay. If your ECG shows that you have ST elevation in at least 2 leads, it means that this patient is having a massive heart attack. Okay. So this is an emergency condition. If you have a ST elevation MI or massive heart attack, you should, if you have aspirin, you should load them with 300 milligram aspirin. If you have Plavix, you should load Plavix and send them immediately to the nearest hospital, preferably a hospital with a cardiac service. Okay. Other than STEMI, there's other non-STEMI unstable angina or stable angina, the other type of ACS. I'm not going to go in the theories or definition, but I'll share with you some cases, for examples of this type of ACS. Okay. the first patient, 56 years old gentleman, smoker, he came with epigastric pain. Okay, his complaint was epigastric discomfort. Okay, so it's the first ECG. If you see, probably there's a suspicious ST elevation, some ST up at the inferior lids, but it's suspicious. But what is obvious if you see the P wave and the QRS. Okay, that's a dissociation between P wave and QRS. I need to finish. Okay, sorry. So this patient have a high degree AV block. Okay, so the repeated is so the emergency doctor did repeated a ECG and now you can see there's an obvious ST up in the inferior lids. So this patient had an inferior myocardial infarction complicated with a high degree AV block. So we pushed him immediately to the cath lab. I did an angiogram. So his right coronary artery is occluded. So we sucked out the blood clot. This is how the blood clot looks like, followed by ballooning and introducing a stent. So this is so on the left is occluded artery, and this is after putting a stent. You get a good flow and full established blood flow. So just to highlight, in this patient, he came with an atypical presentation. He came with an epigastric pain. My experience, I've seen few cases where a patient who had gastric, epigastric pain went to GP. They were thinking of, they treated him as gastritis. He was discharged, went back with the anti-gastric medication. But after a few hours, he deteriorated and he was brought back. And on the way, he collapsed and he actually ended up having a massive heart attack and succumbed. So the learning point here, if you have a typical or atypical, even though you think it's gastric, just do an ECG to make sure that you're not missing anything. And in this particular patient, the first ECG, the ST was slightly, there was some slight changes, suspicious, but the second ECG was obvious. So the other learning point is if you have a chest pain, you should do an ECG, and you ideally should repeat ECG in 10 to 15 minutes. So the other case, 68 years old, hypertension, cholesterol, came with chest pain. His ECG, serial ECG, a repeated ECG was normal. His first cardiac enzymes were normal. So we repeated the cardiac enzymes after 3 hours, and it was raised. So the diagnosis is, so by definition, the diagnosis is non-ST elevation MI. So here the ECG is normal, but the repeated enzymes were raised. So we did an angiogram, and it shows that this patient had 3 vessel disease, and he was sent for a bypass. So in this patient, ECG was normal. The first cardiac enzymes were normal, but repeating after 3 hours, the enzymes were raised. Some centers, when they do an ECG and cardiac enzymes, if it's normal, they normally sometimes they discharge. But in this case, after 3 hours, the enzymes were raised. So ideally, a patient who has chest pain should be admitted and should do a serial ECG and cardiac enzymes. Another thing I'd like to highlight is this patient had normal ECG, but ended up having 3 blockages. So it's important to know that a normal ECG does not exclude coronary artery disease. Patient can have 3 vessel disease, yet a normal ECG. Okay. This is a case of unstable angina. He's 48 years old. He's a smoker with a strong family history of IHD, newly diagnosed hyperlipidemia. He came with chest pain during rest. When I saw him, he was pain-free. ECG and the cardiac enzymes repeated normal. So we proceeded with CT cardiac. CT cardiac showed there was lesion, and there was a tight lesion, and we did a coronary angiogram. Okay, so the angiogram shows that he has a tight lesion in the LAD, and this is after treating with a stent. Another case, this is a 50-year-old smoker. He came to me with a complaint of pain only on exertion. And when he's at rest, he has no symptoms. ECG was normal, so I did a stress test and it was normal. CT cardiac shows that he had. So we proceeded with CT cardiac, and so this is how a CT cardiac looks like. Basically, it's something like an angiogram, but it's non-invasive. Give contrast and we scan the patient, and this is how a picture of a CT cardiac looks like. And there's a tight lesion in. Tight lesion in one of the vessels. So we did the angiogram. He had and stenting was done. So a patient with chest pain, when you see a patient with a chest pain, whether typical or atypical, you should do an ECG. Ideally, you should do an cardiac enzymes. You should repeat the ECG and cardiac enzymes. Again, I just want to highlight a normal ECG and normal cardiac enzymes does not exclude ACS. Okay, and ideally, this patient comes with chest pain should be admitted and should be monitored, because they can have recurrent chest pain or the enzymes can be raised after 6 hours. If the ECG is normal, cardiac enzyme normals, then we should not stop there. We should do further investigation. Either do an exercise stress test, a CT cardiac, or a coronary angiogram if it's indicated. So breathlessness or reduced effectiveness. Okay, so what are the causes? A patient comes with feeling difficulty in breathing. It can be during rest or on exertion. You need to think of coronary artery disease or cardiomyopathy if the patient comes with a heart failure, any arrhythmias, lung disease, pulmonary embolism, even anxieties, depression sometimes present with these symptoms. So how you go about you should take a good history examination. ECG is a must, to an X-ray, baseline blood test. We have this blood marker called NT-proBNP, where if those counts, it's a heart failure marker. When the heart, it can be raised when the patient comes with heart failure. So it's quite highly sensitive and sensitivity is high. So patient will require further investigation, including a stress test or echocardiogram, Holter, MRI, or coronary angiogram. So it's basically an ultrasound looking at the heart. It can give you information of whether the heart is, there's any weakness in the heart, swelling, structural deformities, any valvular issues. So this is an example of echo. On your left, this is a normal heart, and the heart is contracting well, and here it's sluggish. So basically, this patient has a poor LV function. Patient is in heart failure. Cardiac MRI is a good tool. It's the indication is those who have heart failure. You do a cardiac MRI to investigate why this patient having a poor LV function. Yeah, and it can sometimes give you the etiology, whether it's due to coronary artery disease or due to myocarditis. So MRI is a good tool to investigate for heart failures. The other symptom is palpitation. It's one of the commonest symptoms, and there's a lot of etiology, a lot of causes, and the non-cardiac causes can be due to stress, anxiety, or panic attack, depression can cause palpitation. Strenuous exercise, stimulants such as caffeine, amphetamines, medications which contain pseudoephedrine, fever if he's dehydrated, hormonal changes, thyroid problem, or even anemia. Those cardiac causes, most of the time we need to rule out arrhythmias. Okay, arrhythmias which cause tachycardia, examples are atrial fibrillation, atrial flutter. These two normally you see in elderly people. And then there's supraventricular tachycardia, WPW, ventricular tachycardia, long QT syndromes. Arrhythmias which cause bradycardia can be a sick sinus syndrome or conduction block, AV block. Normally you see this in elderly people. And then there's a premature beats and ectopics. Significant ectopics can cause palpitation. And so these are all the causes of ectopics. So again, when you see them, age will actually narrow down the diagnosis. And it can give you an idea whether if you're elderly, then the etiology is different. Like young, it's different. You can narrow down the diagnosis. Whether this patient have other symptoms like fainting, anxiety, chest discomfort. Of course, examination, and most importantly, you do ECG when they come with palpitation. Then you have a baseline blood test. You need to rule out thyroid disease. And when I see a palpitation, I do ECG. I also do a stress test, echocardiogram, Holter, and CT cardiac if it's indicated. I'll tell you the reason why I do this test by giving you some examples. Okay, so this patient of mine, she's a 24-year-old lady, no medical illness. She's been having palpitation on and off for the last 2 years, and each time she feels anxious when she has palpitation. But the last 2 weeks, the reason she came to see me was because in the last 2 weeks she complained of reduced effort tolerance, which is something new to her, on top of the palpitation. Within the 2 years, she visited a few GPs, and she was told that the ECG was normal, and one of them treated her as anxiety and started on Xanax. But the symptoms did not improve. She actually saw a cardiologist a year ago. The blood test, ECG, echo was done and told to be normal. In fact, she was started on beta blockers, but unfortunately she could not tolerate to this medication. So I did a ECG, and what you see here, what is abnormal here, you can see some occasional ectopics, premature ventricular contraction, PVCs. So so the next thing I did was Holter. So if you look at this Holter report, there's a certain time of the day her ectopics are less frequent, and certain time of the day it's very obvious, very frequent and everything. So this explains why in the 2 years ECG could be normal, because her ectopics were quite obvious during the evening, at the evening and night. So daytime it's less obvious and cannot be picked up in the ECG. So this is the Holter report, and it shows that she had 20,000 ectopics within 24 hours. Okay, a normal person, you can have ectopics up to 1,000 within 24 hours. It's significant if the ectopics are more than 10,000, and hers was 20,000. So quite significant. She got a very significant PVCs or ectopic. So the Holter showed that she had a high burden PVCs. I referred her to an electrophysiologist. The PVC was ablated. Repeated Holter, there was no significant PVCs, and she was asymptomatic since then. No medication required. So in this patient, her ECG, in the 2 years, her ECG was normal or had some PVCs, and the poor lady was treated for anxiety. But if you do a Holter, you can saw, I see that she had a high burden of ectopics. And just a bit of, so what is Holter? Holter is basically something like 24-hour ECG. It's a portable Holter. It can be fixed, like a belt fixed, and there's electrodes fixed to your chest, and you actually can go back with it and return back after 24 hours. And why you need to, when you do a Holter, when if you have palpitation or syncopal, and what you can get, for what information you can get, you can assess, you can look for any arrhythmia such as SVT, VT, AF, ectopic in the mentioned in the previous case. Also, if there's significant pauses or bradycardia or AV block, you can detect in Holter. So this is actually an interesting case, a 58-year-old lady, no medical illness. I actually did a case report from this case. She presented with heart failure symptoms. Upon further history, she actually had palpitation for many years, and the doctors, she was told that it was normal. The doctors told it was normal, and there's nothing wrong with her. So echo showed that her EF was 28%. She had poor LV function. Chambers are dilated. Angiogram was normal. MRI showed there was no any structural problem, myocarditis, except that her LV function was poor. So what was obvious was she had quite a frequent ectopics. So we did a Holter, and Holter showed that she had a high burden of ectopics, which is more than 28%. Normal is less than 1%. So she went, she undergone an ablation, ablated the PVCs, symptoms recovered. After 3 months, we repeated the echo, and her echo was actually normal. From ejection fraction of 26%, it went up to 60%. The chamber size normalized, the valve for H was normal, back to normal. She was asymptomatic since then. So this is an example of a tachycardia-induced cardiomyopathy. Okay, so ectopics, if there's a high burden ectopics, if it's not treated for a long time, it can actually cause heart failure. And other than ectopics, atrial tachycardia or AF also can cause a tachycardia-induced cardiomyopathy. So a bit of ectopics. When I was a houseman and I was a medical officer, I was always told that when you see an ectopic, you don't have to worry. It's normally benign, or you just reassure the patient. It can, most of the time it's benign, but sometimes it can be asymptomatic. So when you see an ectopic in ECG, you need to ask the patient whether if they have symptoms, and normally the symptoms the symptoms are palpitation, reduced effort tolerance, breathlessness, chest discomfort, anxiety. Okay, if they have this type of, if they any kind of symptoms, then you need to investigate further by doing a stress test, echocardiogram, and most importantly, doing an Holter to look for the ectopic burden. Treatment-wise, you can start the patient on beta blockers. No improvements, then the treatment will be ablation. So the last 2 cases was palpitations. Patients. The last 2 cases it's about the culprit was ectopics. So other causes of palpitation. So when a patient comes with palpitation, you should do an ECG. ECG can tell you whether he has any arrhythmias, or sometimes you can see an abnormal ECG which may whether it's inherited disorders or syndrome can by just looking at ECG. So, example, this patient he's 25 years old. He came with palpitation. If you look at the lead V4, V5, V6, he has a short PR with a data wave. Okay, so this is a classical sign of Wolff-Parkinson-White syndrome, or WPW syndrome. What is the clinical significance? Okay, a patient who has WPW, there's 1% of risk of death annually, which is quite significant. So if you see a patient with a WPW ECG, you should refer to an electrophysiologist. And normally they will ablate. They will do ablation. It's quite a straightforward procedure, and the treatment is almost 100% successful. Another example is look at the V1 CCG. Look at V1, V2, V3. There's some ST elevation followed by a T inversion. Okay, it is it suggests that this patient has a Brugada syndrome. What is the significance? This patient, they normally present with palpitation or fainting episode. Some will develop VT or even sudden death. Yeah. So when you see this type of ECG, you also should ask whether there's any history of fainting or any sudden death in the family. Again, the treatment is should be referred to an electrophysiologist for further evaluation and management. So why do I do a stress test for patients with palpitation? One is to rule out coronary artery disease and also to look for any arrhythmias. So this is an example of a patient, 39-year-old smoker, had palpitation. I did a stress test. This is a stage 3. The ECG looks okay, and suddenly at stage 4, he went into a VT. Luckily, it was a stable VT. He did not collapse, and it reverted spontaneously. So I referred this patient to a electrophysiologist for further evaluation. Echocardiogram is also a good tool to look for any structural deformity. If you look at the left, this is a normal ECG, normal echocardiogram. The septal wall the thickness is normal. If you look at your right, it's a huge septal wall. Basically, this patient has a HOCM, hypertrophic obstructive cardiomyopathy. Okay. What is a clinical significant? This patient can end up having palpitation, VT, or even a sudden death. Sure. This is a 39-year-old gentleman, smoker with no medical illness. He was in the church when he suddenly developed palpitation, breathlessness, and discomfort. His first ECG was sinus tachy, heart rate was 120, but repeated his heart rate was 80. His blood test was normal, echo, stress test, Holter, everything was normal. During admission, we gave him Xanax. His symptoms improved. He came back again with similar symptoms and improved with Xanax. So the diagnosis was he probably had a panic attack, and we referred him to a psychiatrist. Panic attack, anxiety, stress induced is only a diagnosis of exclusion. Okay. If they complain of anxiety or panic or palpitation with anxiety, you need to make sure there's no. You need to rule out cardiac causes. So the next symptom is syncopal or fainting. The causes of syncopals can be a vasovagal, situational syncope, postural, neurological syncopal, cardiac syncope. Okay. So I'll talk about more cardiac causes of syncopal. Cardiac causes can be due to arrhythmia secondary to coronary artery disease or cardiomyopathy. or sick sinus syndrome, AV block. These two are normally seen in elderly patients, or inherited disorders such as Brugada Syndrome, long QT, or if this patient has severe aortic stenosis, they all can present with the syncope. So how do you manage? Again, age will narrow the differential diagnosis. Look for other symptoms, examination, make sure that they have no murmurs, ECG, and other tests. Again, doing a stress test, most importantly, a Holter, echocardiogram, CT cardia, to rule out coronary disease. And sometimes the electrophysiologist will do a tilt table test or do record an electrophysiology study for those who suspect arrhythmias. Treatment is treating the cause. If it's CAD, then you do an angioplasty bypass. If the patient has bradycardia, significant pauses, or complete heart block, then you insert a pacemaker. Any arrhythmias, then you insert an ICD, implantable cardioverter defibrillator. And electrophysiology study for those who suspect any arrhythmia issues. And for those aortic stenosis, you should do an aortic valve replacement. For murmurs, what are the causes? You can have functional murmurs due to pregnancy, anemia, or hyperthyroidism, fever. Then you have valvular heart disease, any shunts or HOCM. The investigation is by doing an echocardiogram, looking for leakage, looking for shunt. So asymptomatic patient, okay. So those who have cardiac risk factors, if your patient have hypertension, diabetes, strong family history, smoker, then they should do an exercise stress test annually. Stress test accuracy is about 70%. So why do you need to do a stress test for a patient who's asymptomatic? I give you an example. Okay, 51-year-old gentleman, his hypertension, cholesterol, hyperlipidemia, he has family history of IHD. He's asymptomatic, he's under a GP follow-up for his hypertension. So he came to see me basically to do a heart screening. So his resting ECG was normal. His baseline BP was borderline highish, and his LDL is not controlled. So I proceed with a stress test, exercise stress test. This is how a stress test looks like. And this patient's stress test was positive. It was abnormal at stage 3. So I did a CT cardiac, and it showed that this patient has a narrowing at the mid-LAD. Angiogram confirmed that he had a tight lesion at the mid-LAD, and we stented this patient. Started him on a double antiplatelet, and his medication was optimized. So this patient had cardiac risk factors, but he was asymptomatic under a GP follow-up. Angiogram shows that he had tight lesion. So again, so this particular patient had risk factors. He was asymptomatic, but angiogram shows he had tight lesion. So basically, have a silent CAD, and he definitely have a risk of getting a heart attack, whether mild. The risk of getting a heart attack in future, whether it's a mild attack or a massive attack, we wouldn't know. So how do we screen for this silence CAD, coronary artery disease? It's the simple way is to do an exercise stress test, And my advice, if you have patients who are with cardiac risk factors, asymptomatic, even though they are asymptomatic, you should do a stress test annually to screen for this silent CAD. In fact, I normally advise patients who are above 30 to without risk factors to do an exercise stress test, at least 2 years once. Just to recap, when to refer to a cardiologist. Again, these are the list. I'd just like to highlight, I've discussed with you, I've shared with you a few of the cases, and most of the cases, the ECG was normal. So a normal ECG, the ECG was normal, and they end up having a coronary artery disease. Some did bypass, some had significant ectopics, and we treated with ablating the ectopics. So a normal ECG does not exclude heart disease. Okay, if the patient comes with symptoms, you have if you do an ECG is normal, please don't say that you're okay and reassure them, and you need to do a further test, further investigation, including an exercise stress test, echocardiogram, or a Holter, CT cardiac MRI, coronary angiogram, or electrophysiology study according to his symptoms. So again, this is an example of an exercise stress test. This is our CT cardiac. This is how a CT cardiac image looks like. You can actually look at the arteries, something like angiogram, but it's non-invasive. So the risk is, there's no risk in doing a CT cardiac. This is how an echocardiogram look like. This is my cath lab where I do my angiogram and angioplasty. So normally when I do an angiogram, I go through via a radial artery at the wrist, and if I have difficulty, then I do through the femoral artery at the groin. So we put a small tube in up to the ascending aorta, connected to the coronary sinus, and we take a shot, and this is how a coronary angiogram looks like. This is how a stent this is what a stent looks like. And my final slide, I'll just share with you an animation of basically how a plaque formation, how a plaque form. It takes this process takes at least a few years to form a plaque formation. It causes narrowing of the artery, and it slows down the flow of the blood. And how you treat? You introduce a wire, you introduce a balloon, and you widen this narrowing. You open up the tight lesion with a balloon, and the next thing is you introduce a stent, and you inflate the stent according to the size of the vessel wall. So you achieved a good blood flow, and the lumen of the artery is patent. Normally the stent is drug-coated stent, and it also treats the wall of the artery. So with that, it's my last. This is the end of my presentation. Thank you. And if you have any questions, I will be happy to answer. Sorry for the technical problem. In fact, I had to change computer in between, and it was quite a haywire. Okay, so one of the question is asymptomatic frequent PVC. Does this require further investigation? If your ECG shows frequent PVCs, even though the patient is asymptomatic, I still will investigate. I will do and most important is basically I will do an Holter for this patient is to look what are the numbers of PVC within 24 hours. If it's less than 1,000, then you don't treat this patient. But if it's more than, but if it's significant, if it's more than 10,000 PVCs within 24 hours, then this patient probably needs treatment of further evaluation. Other than Holter, I also do a stress test and echocardiogram to just rule out any structural abnormalities. Okay, one of the question is What is the earliest time you can detect ECG changes and increase troponin level, onset of chest pain, and how you diagnose entry MI, acute MI in the first 1-2 hours? Okay, if a patient comes with chest pain, if it's acute myocardial infarction, the ECG normally shows ST elevation MI. But if it's normal, then you should repeat the ECG every half an hour if this patient has severe chest pain. And sometimes the first ECG can be normal, but the repeated one can show changes, and and TROP-T can, the first 3 hours, the cardiac enzymes can be normal. So again, a patient comes with chest pain, you should repeat the cardiac enzymes after 3 to 6 hours. The first 3 hours still can be normal, especially those who come with myocardial infarction. Going through the questions. Okay, there's a question: a 68-year-old's hypertension, diabetes, metformin, echo normal. Does this patient needs to go on Plavix, and for how long? So the question here is, this patient has risk factors: hypertension, diabetes. He's 68 years old. The guideline says that antiplatelets, normally aspirin or Plavix, you start them for secondary prevention. That means if this patient has a heart attack, confirm having had a heart attack, or CT scan shows that he has plaque formation, then you start them on antiplatelet. But those who have no evidence of heart disease but only have diabetes and hypertension, I will not start them on blood thinner. So in another way, you don't start a blood thinner or aspirin Plavix for primary prevention. You only start them for secondary prevention if it's proven that this patient had heart disease. And how do you screen for that is by doing a form of stress test. If your stress test normal and this patient sends, then I will not start the patient on. If the patient has no symptoms, then I will not start them on Plavix or aspirin. So how to be sure if it's ACS, since the ECG and cardiac enzymes are both normal? Again, how to be sure if the patient comes chest pain, enzymes normal, ECG normal, then you need to do further tests, like doing a stress test. Depending on the symptom, if he's still having symptoms, then I'll straight do a CT cardiac for him. But if his symptoms is just on exertion, and then I'll probably do a basic stress test, and if that's abnormal, then I do a CT cardiac. So that's so I don't depend on ECG and cardiac enzymes. I still do it. You should do a stress test, at least a stress test, CT cardiac, depending on his symptoms. So there's one question: anxiety, depression patient need to do heart screening annually to rule out heart disease. It depends on the one. Is if the patient is young, if they are having anxiety and depression, you just probably you need to just for once you need to do a screening, do at least an ECG stress test, just make sure that there's no any rhythm problem which causing anxiety. Like example, the case which I mentioned, ectopics. Make sure there's no frequent ectopics or any arrhythmias which causing her to have anxiety. And if it's normal, then you don't have to screen them every year. But if it's elderly patients, I mean, if you are above 30, normally I advise even generally, whether you have anxiety or not, to screen a patient. You should go for screening every year once you're above 30 years. Especially if you're more than 35, you should do screening, regardless whether you have anxiety or depression. Okay, I got a question here. Is it a good idea to do annual stress test for elderly patient? who has hypertension, diabetes, dyslipidemia, without any symptoms. So depending on their age and how fit they are, when you say elderly, if they are 60 and they can, because when you do a stress test, basically you are walking on a treadmill and you do a brisk walk, and you hardly run, so we don't normally make them run. So you still can do a stress test, even though the patient, but if you can't, you do stress test for them. So you go based on the symptoms. If they got no symptoms, then it's just medical therapy, meaning optimize their hypertension, diabetes, cholesterol. But if they have symptoms, then you need to investigate further. Do you advocate stress tests for all patients above 30 years? Yes. Yeah, I do. Even though they have no medical, if they have no medical illness, I still advise patients to do a stress test or any form of heart screening once they are 30 years. In fact, even if you start earlier, because looking at our statistic, the government statistics, patients are getting heart attack in a younger age. The numbers are increasing. My youngest patient who had a heart attack was 22 years old. So he was a smoker. He had no medical problem. He was a smoker for 10 years. And he was only 22 when he had a heart attack. So to me, at the age 20, you should at least do a baseline blood test, looking at your cholesterol, sugar, blood pressure. And every 5 years, you should do a health screening. And once you're 30, you should do at least 2 years once. And when you're above 35, you should do annually. Yeah, that's my thing. Diabetic hypertension above 60 years, do you start aspirin? No. Again, primary prevention, aspirin is not indicated in primary prevention. So a patient with diabetic hypertension, I will not start them on aspirin unless there's evidence of a blockage, or the patient has stroke or heart disease, then aspirin is indicated. But if there's no any evidence of coronary artery disease or stroke, I will not start the patient on aspirin. And the guideline says you don't treat patient with aspirin for primary prevention. You only start aspirin for secondary prevention. So patient with diabetic hypertension, I will look at the cholesterol, and if the cholesterol is borderline, I normally start them on cholesterol rather than aspirin. In fact, cholesterol is way better in reducing cardiac event compared to aspirin. Any difference between male or female when it comes to screening? No. To me, both male, female, young age presented with heart attacks, so there's no difference. They should start screening at a young age. Okay. Thank you, Ian. I'll pass it to Valerie.
Okay, thank you, Dr. Nanda, for the very informative presentation. Sorry for the technical issue earlier. So we thank you everyone for coming. We appreciate you being here today with us. We are going to have webinars like this in the near future. So if you are available at that time, we hope to see you again. So once again, thank you everyone, and hope to see you next time.